Here we are again. Today I'm going to talk about the thoracic imaging procedures. Uh, there's a lot of things that we can do in the thorax, but basically I'm just going to go over some things that are general and that we might see. So if we start the general thorax notes, always if we're seeing the thorax, and we're going to usually say this is a chest CT, you're going to start always above the apices because we want to see everything, some soft tissue. We don't want to see any lung when we start. So the first image should not have lung in it from the above the apices all the way down through the costophrenic angles. If there's cancer or a neoplasm suspected, we're usually going to go down through the liver and the adrenal glands. Now, this is almost always done in most places, whether they expect a neoplasm or not. So we're going to go down to the top of the kidneys to the adrenal glands. You're going to always view this in two windows, either a soft tissue window or sometimes called a mediastinal window, and a lung window. The patients are going to be supine with their arms raised above their heads. Contrast may or may not be used. It's according to what you're looking for. If you're looking for mediastinal masses, or if you're looking for anything PE or vascular things, obviously we will use contrast. If we're just looking for nodes or to assess nodes or possible masses, we're probably not going to use contrast. A high resolution scan is going to give us superior detail, and we're going to use that for some of the images that we do. So again, this is just some general notes that we would talk about here. A short scan times helps reduce the artifacts created by respiratory motion. Well, we use a short scan time on almost everything we do. Now then, the modern scanners are going to be done with a single breath hold, which is going to be called a spiral scan or a volumetric scan. Yes, if you're doing biopsies or other things, you're going to do single slice, but generally we're going to use a volumetric or a spiral scan and do this in one breath hold. Uh, because that you have a high intrinsic contrast from the lung tissue to the soft tissue and the bones, we don't usually use contrast. So IVA agents are typically used to differentiate vascular from non-vascular structures. Again, that's usually in the mediastinum. High-resolution CT scans of the chest were used in assessment of certain lung diseases and the parenchyma, the whole border of the lungs, and with diffuse lung disease. These are usually done supine and prone because in case there's a little bit of fluid that collects, we want to see anything. So we usually do these supine and prone if we're doing high-resolution scans. Spiral scans, we use that to do the chest. That's done entirely in one breath hold. It's probably the most important advancement in chest scanning because we don't get what's called misregistration. That's when you breathe a deep breath one time and a shallow breath the next time, a deep breath one time, a shallow breath. So if you do it in one breath hold, you don't get the chance of missing something between breaths where you expand the lungs and they move up and down. We get good 3D reformations, and it is good for vascular studies because we can give that bolus of contrast and see the contrast all the way through the lungs in that single scan. When we're doing single slice scanning, but the time the contrast was in the lower lungs, it did not look like it did when we were in the upper part of the lungs. Scan levels, again, we've said that from the apices to the posterior costophrenic angles, but most places are going to go through the adrenals, which are just on the top of the kidneys. Again, we've said patient supine, breathing full inspiration on a single breath hold. We want to expand those lungs as much as we can. And obviously, we're going to do this as rapidly as we can with a rapid scan time. We have several different reconstruction algorithms. A high resolution algorithm we see optimizes lung detail, but we do get somewhat of a grainy appearance, but you get better superior spatial resolution. Standard in soft tissue, a little bit smoother image, not quite as high a spatial resolution, but you get better contrast resolution. Optimal, it's the best for vascular structures and mediastinal structures. Again, the stuff that's not in the actual lung itself. Window settings, and these vary greatly from place to place. You may have a lung, but you're usually going to use, well, the lung window setting best demonstrates lung anatomy and pathology in the lung. So the level, we talked about windows and levels in another lecture, but the level or our mean, the mean or the average setting is going to be somewhere between minus 600 to minus 700. The window width setting, that is the grayscale, is going to be somewhere between 1000 to 1500. These are general notes. Remember we said we set the level at about the CT number of the image of the structure that we want to see. Well, we know that lung tissue is not completely air because air would be minus 1000, but lung tissue would be minus something less than 1000, so it's a little bit denser than air, but still it's in the minus range. So we remember we set the levels that usually correspond to the tissue of interest. If we're interested in the lung tissue, the CT number of lung is somewhere 6 to 700. The mediastinal or soft tissue window setting is going to show anything else, the fat, the soft tissue, fluids, contrast media, and everything else, and even calcifications, because the calcifications usually will not be as dense as bone. The level or mean window setting in this is 20 to 40, because that gets a lot of soft tissue. It might be as much as 60, but somewhere in that range. Let's just settle on somewhere maybe 50 to 60. The window widths are 450 to 500 because again we don't need as longer grayscale. So those are some general settings that we might see in that area. I thought I had my pointer on. I'll put it on again here. So this is an example of where we have a long window setting where you have it's very gray, but we see the lung tissue much better here, but we don't see things in the mediastinum very well. Here we have a mediastinal or a soft tissue window setting. The lung appears black. Yes, we can see some things out here, the lung, that are some pathology, but what we really see is this mediastinum. Look how we can see this pulmonary artery here with the right and left branches. We can see the superior, the ascending aorta, the descending aorta, and the little bit of the inferior vena cava here tucked in the corner. We can see the two bronchi here. We can see the esophagus back here in the back part. And we can also see those azygous veins there. So we really get a good area in this area when we do the mediastinal setting. So you want to see the lung tissue itself, and then you want to see the things in the mediastinum. Um, this is just an example. I'm just going to go into some common findings that we might have. So if we had Hodgkin's lymphoma, this is just a scan. And again, we're going to see that in the mediastinum because it's going to be those lymph nodes in the mediastinum that are enlarged. So even on this chest x-ray, we can see that there's something in the mediastinum. When we do the CT scan, then we can see these huge nodes. This should just be really, we should see almost no soft tissue here. So these are huge nodes. Can I say for sure those are Hodgkin's lymphoma? Of course not. We're going to do some kind of biopsy. But the appearance here is that there's some kind of enlarged nodes in the mediastinum. It is likely Hodgkin's lymphoma or some type of lymphoma because those lymph nodes are enlarged there. If we look at pulmonary nodes, pulmonary singular nodes are usually benign. A single node usually may have a smooth border, may be calcified, and they're usually benign. An example is here, set in the lung window. This is set also more in, this is a different window, but you can see it more of a mediastinum. And again, a single node. Can I prove that that's benign? No, but the doctors have charts that help them look at certain things and know if it might be benign or if it's not benign. But some things that we might look for to say that it is benign. I don't know if this will go back, so I'll try to keep going forward here. If it's a lung mass, they're usually malignant. And this is an example of a metastatic lesion where you have diffuse masses all through there, and they tend to have irregular or fuzzy borders. Whereas, and you can also have a single mass, but again, it's not nice and smooth border. It's flocculated there. And this particular one was from a breast cancer. You can see this person has had a breast removed, so a breast cancer that has spread to the lungs. It is a single mass here, but later on we may see it in multiple masses here. We're going to use IV contrast when we want to see anything in the aorta. So an aneurysm can be differentiated from other mediastinal masses? Well, usually we can see an aneurysm pretty well, but we can see it much better when we give this contrast here. This is an example of a dissecting aneurysm. We have the contrast going here, and this is somewhat more static blood where it may be out in that bulging part of the aorta. We can see, again, we can see that little line there in that aorta. And again, here in this part of the aorta, this is kind of messed up looking. So highly accurate in detecting and to the extent of traumatic aortic ruptures and dissections. So aneurysms can be differentiated from other masses because the masses will not contrast and the aneurysm will contrast, as you can see here. This, I should have had this back over with the nodes and masses. These are just some different classifications of how calcifications look in this picture A. Of course, when I'm recording, I always want to sneeze here. Um, when you're looking at these, and from this different calcification patterns, this would be diffuse, concentric this bullseye, central, popcorn, or concentric targets. These are some of the things that the doctors look to try to decide if a if a lesion is malignant or if it has the calcification patterns of being benign. So this is just some examples of that, where you can see this D is a concentric circle, this C is a bullseye where you got mass around there. I don't expect you to know those, but these are just some of the things that you might look for if you look these up to give you different calcifications of what the pattern might look like. Again, the doctors use those somewhat into diagnosing if the malignant was if the lesion was malignant or benign. Here is a high resolution HRCT, high resolution CT, and it's really used to diagnose things that are this particular one says it's a lymphangitic carcinomatosis. Okay, I can't even say that. What it's saying it's from a lymphatic carcinoma. It's an established method for evaluating diffuse lung disease. So the high resolution scan, basically what I want to say is the lung disease is diffuse throughout the lung. We see that also in the diagnosis of asbestosis, silicosis, and anthracosis. Anthracosis is black lung, that what we would see in the miners that work in the mines mining coal. Silicosis, when you work with the people that work in glass or sandblasting, and asbestosis, people that have worked or been exposed to asbestos. All of those have that same appearance where you get a very diffuse pattern across the lung here. It's more sensitive than chest x-rays for detecting emphysema also, so we may use a high resolution scan for emphysema, which we'll see next. It's replaced bronchography for detecting bronchiectasis. So if we're looking for bronchiectasis, we might also use this high resolution CT. This is an example of emphysema with a high resolution scan. If you can look, all these little black, not the white, but those little black lesions all through here, they're called cystic lucent lesions. We can see through them. So what basically has happened that the walls of the alveoli have disappeared and expanded, and so you just get little pockets of air just stuck in the lung. It doesn't breathe in and out, so it doesn't have any visible walls. So it looks like just little pockets, just little black pockets out through here. Again, a high resolution CT scan would help diagnose that. A pneumothorax, we know what that is. That's just free air in the thoracic cavity. This is two examples of that, where you have a huge pneumothorax here. You have a pneumothorax here. Probably this may be why the person has the pneumothorax. Looks like maybe they've had something that pierced the chest wall here. This can be spontaneous, but usually it's from some traumatic injury. A rib broken or something has punctured the lung, punctured the chest cavity, deflated the lung, and then this air is here. That air is not going to go away. This is free air. You can see there's no lung markings here. It's just free air, and then the lung has shrunk. The lung can actually completely deflate, and you're going to have a chest tube to correct that. Pulmonary edema, that just merely means there's fluid. Obviously, this person has something going on in their lungs, a lot of things going on, but we see fluid collecting here. Pulmonary edema can be from many things: congestive heart failure, disease. It just means that we have fluid in the lungs, and we can see it certainly collected here. A pulmonary emboli. Those are something that's really serious because the statistics show that untreated PEs result in about a 30% death rate. It's the third most common cause of death in hospitalized patients. Probably, well, if you're as old as me, you've known someone that went in for surgery or had some kind of other problem, and they developed a maybe uh, deep vein thrombosis in their leg, or sometimes the abdominal surgeries can result in throwing a clot, and so you get a pulmonary edema, and the patients are likely, well, there's a high death rate from that. Uh, but some of these pulmonary emboli, that's just a where you got a blood clot in the pulmonary arteries and the branches off of the pulmonary artery. Many of these are maybe not may they may be non-symptomatic, are symptoms from very mild dyspnea, difficulty breathing, to severe chest pain. So probably a lot of people have had small PEs and never knew it. The body broke them down and dissipated them, but it's those large ones that block rapidly, and then you die from that PE. These symptoms can also be from other diseases. So you can have dyspnea and severe chest pain that are not PEs. But if you've had surgery or some kind of crushing injury, or you have a history of having blood clots, then you might suspect a pulmonary embolus if you had these chest pains, and usually if they're sudden onset. There's a test called an ELISA test where it's a immunoabsorbent assay test. It's called the ELISA. Basically, it's called a D-dimer. I just want you to be familiar with this term because it has been mentioned in the registry before. So a D-dimer test is what the test is called. It's an ELISA test. A positive D-dimer, if you do the blood test and it's positive for a D-dimer, it merely indicates that there's a high probability, there's a presence of an abnormally high level of fibrogen degradation. In other words, you've had a clot that is breaking down in your body. There can be clots in many different places. They do not have to be in the chest. It indicates that there has been significant clot formation and breakdown in the body, but it does not tell the location or the cause. It can be from many causes: pregnancy, surgery, a myocardial infarction, and from cancer. But you put that with the patient's symptoms: sudden onset of chest pain, shortness of breath, and they have had possibility, they've had surgery, they've had injuries, and then you do this D-dimer and it's positive, then you can be pretty sure that it's a pulmonary embolus. A normal D-dimer test indicates most likely that there's no acute condition or disease causing the abnormal clot formation and breakdown. So a negative D-dimer is most valid and useful when the test is done on patients that are considered to be low risk. We don't really think they've had one, but we'll do a D-dimer and we'll say that they have not, they may be having pain and problems, but it is not from a clot that is being broken down. The test is used to help rule out clotting as the cause of the symptoms. So if we're doing a CT scan and the pulmonary embolus, then there's other tests that we have used in the past. I'm also a nuclear medicine tech, and that's been a long time ago, but when we first did nuclear medicine scans, almost anything that we ever got called in an emergency was for to check for a PE. This was before CT was widespread, and certainly before we had the rapid CT, where that we could do the CT and show the pulmonary arteries here full with contrast. So there this is more sensitive than a ventilation perfusion, which is a nuclear medicine scan. But one time it was the main way that we did PEs. Emboli are seen as filling defects in the pulmonary arteries. We're going to give a rapid bolus and we're going to do some tracking. So we're going to see this pulmonary artery, and this is a good example. This person is not doing well at all. So this should be all white with contrast here. But look, we see this clot here. There's a clot going here where it divides. There's a clot here. So they've got clots in the main pulmonary trunk, or where the trunk is dividing, and then we got clots and out in both of the right and left pulmonary arteries. So that's a good example of that. But this is the example where we do give contrast, because we have to light these up and see where the clots are. We can also do CTAs. Chest scanning has really come a long way. CT chest scanning with the rapid scanning in looking at heart disease. Before, because the heart beat, and that's always been the problem with nuclear medicine, with X-ray, with anything, because the heart is always moving. While I need to slow the heart down for my CT scan, I certainly don't want the heart to stop, because let's see, then the patient's dead. But we can do something called CTAs, and if we look at this, this is just some general things that we can look at. We can see the coronary arteries here. We can also see contrast in the the ventricle here, and then we can do a reconstruction and so the coronary arteries overplace the heart. And this is a calcium scoring where we did not give contrast, but we're just doing a calcium scoring and look at the calcium here. So there's several things we can do. So if we talk about CT angiography or CTA, or CT coronary angiography in particular is what we're talking about here. So we're able to do that because because we've had improvements in CT detector technology. In other words, we have much better definition, we have better detail. We've made great improvements in temporal and spatial resolution. Temporal resolution just is talking about the time, how we've shortened the time we can do a very rapid scan. And spatial resolution is just seeing one object separated from another, so it's easier to see if there's bits of calcium or if there's other things going on. These improvements have resulted in clinical results with cardiac CTs that are similar to those obtained what we used to do with conventional heart cath or coronary angiography, but not CT. So we still do angiography, but CT is coming a long ways, and it's much easier to do a peripheral injection in the arm and do a scan than it is to put a catheter in through the groin or through the brachial artery, a catheter into the artery and go into the heart. So we're doing it's a lot less invasive and it's quicker, and the patient can usually go home that day. They don't have to stay in recovery because they've had an arterial puncture. Uh, but it's important that the technologists doing this CT angiography, that they understand the structure of the heart, the anatomy, the pathways of blood flow, and the timing of the circulation, and the things that have an effect on these timings of circulation. Now, our CT machines have come a long way to make this better and to help us do that. Cardiac scanning, again, has been made possible because we have the very rapid scanning where we can do the entire chest in about a second or two with a single breath hold. We can do extremely thin slices, so when we do reconstructions, we get great 3D reconstructions. And we have EKG or ECG gating, where we put the EKG, I say EKG because I'm old school, it's ECG now, electrocardiographic gating. So we put the monitors on there and we obtain the images at the lowest movement of the heart. The heart's always moving, but we can do several things to try to slow the heart rate down. So it's for the first time we're able to study the coronary arteries non-invasively. When I say non-invasively, we're not having to go and do a heart cath and put a catheter into the artery. And if we're just doing a calcium scoring, we don't even give contrast at all. Um, with this imaging, we have the ability to assess the coronary artery calcification. We can look at how much calcification we have. We can obtain a coronary angiogram where we see the coronary arteries, that right and left, and left anterior descending, and then the small branches off of that. And then we can do 3D images of the coronary arteries and of the heart itself, and also of the ventricles and the atria of the heart. So if we're looking at cardiac CT techniques, again, our objective is to reduce the motion of the heart so that we can get good scans. That's always been our problem with imaging the heart because it's always in motion. But there's several things that we might do to slow the heart rate down or make it more steady. There are some patients that are not candidates for CT heart scanning because they have an irregular heartbeat, which you can't gate because it doesn't have an irregular pattern, or it's very irregular, or that you cannot slow their heart rate down enough. But to reduce motion artifacts on the CT image, a patient's heart can be temporarily lowered by administering beta blockers. Not everybody can take a beta blocker. So takes a very good coordination between cardiology and radiology to get these heart scans. At the place where I do clinical with my x-ray students and sometimes with the CT students, they have a heart and vascular unit. So I see them do these scans and it's amazing what they can do with the heart scans. Not every one of the CT techs works over in this department because while it is still radiology, it's a branch off of cardiology because they work really more closely with the cardiologist than they do the radiologist, even though the radiologists still read the exams. So we can do cardiac gating, and that's where we put the EKG monitors on, or used attempts to use only images acquired during the periods of the lowest cardiac motion. And we can do that using prospective ECG triggering or retrospective ECG gating. We're going to talk about those in another slide. Prospective EKG or retrospective EKG. I'm sorry, I keep saying EKG. Your book says ECG. Because it was KG, because that was the German spelling of cardiac. It started with a K, and they first did this, so they called it EKG because they spelled cardiac with a K. Now we in the English we spell cardiac with a C, so it's ECG. Most institutions also give patients nitroglycerin. That is a vasodilator because it helps those coronary arteries to dilate, so they're expanded. They have a better blood flow. But the diseased part of them tends to not react to the nitroglycerin, so it accentuates what's the normal artery and what's the constricted artery. But the nitroglycerin is a vasodilator that lets us see the arteries better. So that's usually given to patients sublingually. Intention is to dilate vessels to improve the visualization of them. Um, Pharmacological heart rate control, again, that's using drugs, and the beta blockers are used to lower the heart rate. We would ideally they would be somewhere between 60 and 70 beats per minute. Now that might be a normal heart rhythm for somebody, for it's in pretty good shape. So we want it to be at least this low to try to get a good image of the heart. The decision to give beta blockers and the dosage given has to be made by the physician, the nurse practitioner, or the physician's assistant. We can't make that decision because beta blockers can also cause problems, and not everybody can take those. To avoid complications when beta blockers are used, strict guidelines must be followed, and those would be you would know those if you were working in a cardiac unit. We just talked about the ECG tracing or gating a second ago. So really, to understand how a ECG gating is used in CT, we have to have a little bit of understanding of what an ECG is. It is just the graph that shows the heart rhythm, the peaks and valleys of when the heart is in constriction and when the heart is in relaxation. And there's a normal pattern that a person would have. There's variations on this pattern, but the cardiologist can tell those. I had to do a little bit of studying on those when I was doing my registry for cardiovascular. I must say I just learned them. I don't know how to utilize them that well, but I learned them what was an abnormal pattern and what was a normal pattern. And a lot of people do that because we have EKG techs that do that all the time. So the ECG provides a profile of the heart's electrical activity over a period of time. Each heartbeat in a normally functioning heart exhibits a similar characteristic pattern consisting of 5 waves. And so we know that it's the PQRST peaks. We're going to say the distance between the two R's, this is the R here and the R here, that is one complete cycle or one complete heartbeat, sometimes referred to the R to R interval. This shaded area here is the area when we would like for our scan to take place so that the heart is at one of its lowest motions here. It's had its peak motion, it's dropped down, and so it's just at this lowest motion. That is when we would like to do the scan. So if we have an EKG monitor on them, then we know when that happens. So if you're doing prospective ECG monitoring or triggering, it acquires images only in those portions of the cardiac cycle expected to have the lowest cardiac motion. Well, we have them on the EKG. That EKG machine then tells our X-ray, our CT machine when to gather the information. So you just gather the information at the lowest cycle of the heart. It uses a signal usually derived from the R wave to trigger an axial mode image scanning or acquisition. The advantage of using the perspective is that we minimize the radiation dose because we only gather information at the point of the lowest heart activity. It's very sensitive to cardiac motion, artifacts, and image misregistration. In other words, breathing or any kind of motion, it really messes this EKG scanning up. It's particularly problematic for patients with irregular heartbeats. Some of those you cannot do because you can't get a standard enough pattern that you can get the machine to accurately record this. They can do retrospective ECG gating. That means that we are going to gather in the helical scan, we're going to gather the information during the entire heartbeat, but then retrospectively, looking back, we're going to go and just pull out the portions of the heartbeat that was at its lowest motion. So we're scanning everything, but then we're just pulling out the information we use. Well, if we're doing the entire scan, as a general, imaging reconstruction is performed at 60 to 65% of the heart cardiac cycle. The primary disadvantage of doing this is that we scan the entire time, and so we have a higher radiation dose because we're not just scanning at the lowest time. I don't know which one of these is the most common used method, but this perspective is when you set it up and only scan. What I want you to know is that perspective is when you plan it and you're only going to scan at the lowest motion. Retrospective, you scan all the way through and then you go through and electronically get rid of the information you don't want and keep the good part, but you have a higher radiation dose there. Contrast agents, well, we've already talked a little bit about contrast agents. We don't use them in some of just the nodular scanning, but anything if we're looking vascular, we have to use the contrast. If we want to see the mediastinum and differentiate between nodes in the mediastinum and vessels in the mediastinum, then we're going to use contrast. Usually we're going to inject contrast at a fairly high rate. Injections rate of 3 to 6 mLs per second are pretty standard because you want to give that bolus contrast. You want to fill that aorta or that pulmonary artery up with contrast so that you can see if there's any kind of aneurysm, if there's a tear, if there's a bleed, or if there's a pulmonary embolus. Injection usually begins 10 to 30 seconds prior to the scanning because you want to see what's going on before you get before you see contrast, and then you'll scan usually all the way through to the contrast clears a little bit out of there. But you have to have that bolus. So the exact timing of a scan to start is usually accomplished via bolus tracking, or something may be called smart prep. But you've all probably done this if you've done any PEs, where you put an ROI, where you do a circle in the region of interest in the ascending aorta for a CTA. If you want to see that entire heart, then you're going to do the C. It's got to be there because you got to see the blood flowing out into the heart and to the coronary arteries. A Hounsfield unit or CT number reading of approximately 150 in the aorta triggers the exam to start. When you get enough contrast in the aorta, being about 150 Hounsfield units, then your scan will immediately start that you have previously set up the parameters. Contrast injection is immediately followed by a saline chaser. In other words, almost all modern contrast injection machines are going to have a saline hooked up to it also that will flush the contrast out of the tubing and then clear it so that it also dilutes the contrast just a little bit so that the bolus isn't so dense. If the bolus is really dense, it can make streaking when it comes into the superior vena cava because it's coming into the heart through the superior vena cava, and if it's a real dense bolus, it can make streaking because of the density of the contrast agents. We can also do something called CT calcium scoring. This is old information. Nobody uses a 4 detector row, but this is just saying that you had to have at least a 4-row detector. Nobody has that. Everybody uses more than that now, but this was when this was written. But that was the minimum, and you had to have at least a half a second gantry rotation time. So you really had to have the new equipment that was fast scanning and had multiple rows of detectors. No contrast is used in the calcium scoring. It would obscure the calcium plaques in the arteries. And so this exam can be self-referred because I know at one of our heart centers here, for a fairly low price, you can come and ask for a calcium scoring, and they will just do that over your heart. I know two or three of my former X-ray students slash now they're CT. They work in there, so they said, "Mr. B, you're getting kind of old. Maybe you should come and have that done." I did have an ultrasound done of my carotids, and the ultrasound techs here at where I work said that they were clear as they could be. So I feel good about that. That's just a little side note. So we're not going to use any contrast in the calcium scoring. The amount of calcification seen on the cardiac CT on the calcium scoring is expressed as a calcium score. And the part of this is the technologists do it. Part of it is the the AI, the artificial intelligence of the machine, being able to pick up the calcium and gives it a score, a percentage of how much the artery might be blocked. Because the coronary calcium measurements is done mainly as a screening examination, usually in asymptomatic patients, I could just go and say, I just want to know what I look like inside if I have coronary artery disease. That might make me straighten up and stop eating so much fat and exercise more. I don't smoke or I don't drink that much, so I don't have to worry about those things. But drinking, smoking, lack of exercise, diabetes, unchecked high blood pressure, all of those contribute to coronary artery disease. If I have a wake up call, then maybe I would straighten up and not do some of those things. Um, Coronary artery calcium scoring. Coronary artery disease is the number one cause of death in North America. So we know, and worldwide it's scoring also. Coronary artery calcium scoring can be used as a predictor for a future myocardial infarction because it tells how much those coronary arteries are blocked. Previously, we used something called the Framingham Risk Factor Assessment was used. It was only 60 to 65% accurate in predicting a acute myocardial infarction. But the things that we considered that were considered when they were doing this Framingham study risk factor was your age. Obviously, the older we get, the more likely we are to have coronary artery disease, high blood pressure, high blood cholesterol, smoking, and diabetes. All of those factors, and if you had those factors, they looked at those, and without even looking at your heart, they could give a prediction, and they were 60 to 65% accurate without even looking at any picture. If it's certain age, certain blood pressure, cholesterol, if you smoked, and if you had diabetes, and you might say overweight also. Those were good predictors. Now we can see it directly. 60 to 65 images are taken, areas of calcification in 5 major branches of the coronary arteries. Certainly the right and left main coronary artery, the left anterior descending, and some of the branches also. They look in 5 different areas. Each plaque is assessed a score and based on its density and the area located. Values are adjusted for age and the gender or the sex of the patient. So to see how severe that is. The gold standard for arterial studies has been the coronary angiogram, what we call the heart cath. But CT has really come about in this. It is very sensitive and specific, and predicting a patient that truly might have coronary disease or that does not have coronary disease. And it is much quicker and it's much easier and cheaper than doing it in the cardiac unit. So anything that we can do quicker, easier, then why would we not do that? Cardiac out. So some other things that we can do with cardiac functions with CT, you can do cardiac output. These can be done also with a nuclear medicine, and to some degree, you can see the heart motion in some degree with sonography. So the cardiac output is how much blood is volume of blood over a determined period of time, usually per minute, is the cardiac function. The ejection fractions is on each heartbeat. How much when that heart squeezes down, no, all of the blood never leaves the chamber, but what percentage is pumped out on each heartbeat? So it's the percentage of blood ejected or pumped out from the ventricles versus the amount that is left in the ventricle. So the higher your ejection fraction, the better your heart is pumping. Just think of squeezing your fist. If you had a water balloon in your fist and you barely squeezed it, not much water would squirt out. If you squeezed it really strongly, all the water would squirt out of the balloon. So that's an ejection fraction. And the stroke volume is how much blood is the volume of blood pumped in each contraction. So you do the stroke volume and the cardiac output, and you can get the ejection fractions. So you can look at all 3 of those things: cardiac output, the volume ejected, the volume pumped in over a period of time, usually a minute, how much the ejection fraction on each heartbeat, how much is pumped out, and then the stroke volume, the amount of blood pumped in each constant. The amount of blood, and this is the percentage of blood versus this pumped versus the amount of blood that's left in. So you get a fraction. We certainly do CTs for trauma of the chest. We look at everything in that. We look at for lungs. We look for the bones. We look for anything that's going on when we do a chest CT for trauma. So it evaluates the diaphragm. We can see if the esophagus. We can see the spine. We can see the lungs. Anything in that whole thoracic area. Demonstrates blood in the mediastinum. If we have a rupture of the great vessels, that's something we really worry about in chest impact. It demonstrates interlumen thrombosis, in other words, blood clots in the lumen of a artery, of a vein, or sometimes an artery, but more often a vein in this case. Well, no, when we're up here, it can be veins and arteries. Mediastinal air, we should not have any free air in the mediastinum. The only air in the mediastinum should be either in the esophagus, because we have air in our esophagus, or in the trachea or the bronchi, and it should be contained in there. A free air indicates that you've had some type of rupture in the esophagus, or more often in the bronchus, and there's air out into the mediastinum. Esophageal herniation and above the diaphragm. If our esophagus, if we have a hernia, and sometimes even our stomach can, the whole stomach or part of the stomach can herniate into the diaphragm, especially if it's torn. And so we could look for that if we have abdominal contents in the chest cavity, and that would be from a torn diaphragm. And this is just an example of what we might see. We have a ruptured diaphragm. This is the lung. You can see the entire stomach has come up in the lung. Um, this is mediastinal air. This is free air in the mediastinum. This is air in the in the bronchi here. The esophagus should just be a little round circle here. For some reason, there's free air here in the mediastinum. So something has happened. And this is just the x-ray of this. You can see that the stomach has gone above. That's the diaphragm there. The diaphragm should be right here. The entire stomach has gone into the chest cavity. When we did the CT, you can see there's air and there's fluid in the stomach. And so that's a great example of that.